This is Professor Nicholson lecturing on nursing care of the newborn with special needs. Please review the following subcompetencies on your own. The following are factors that affect fetal growth. Most newborns are born between 38 and 42 weeks gestation and weigh approximately 6 to 8 pounds, but variations in birth weight or gestational age can occur, and newborns with these variations have special needs. So gestational age, as a little review, is how many weeks of pregnancy the patient is. So in regards to birth weight variations, we determine this typically by using a tool such as the Fenton, F-E-N-T-O-N, growth calculator. That's what I utilize in my practice. So we determine if a newborn's AGA, SGA, or LGA. AGA, I say average for gestational age, or you could also say appropriate for gestational age. This is approximately 80% of the newborn population. They have a normal height, weight, head circumference to body mass index. Small for gestational age, these newborns are less than 2,500 grams at term or below the 10th percentile. So the 10th percentile is important to remember. Large for gestational age, these newborns weigh greater than the 90th percentile, again, something you should know, on a growth chart, and this is greater than 4,000 grams at term. Assessment of the SGA newborn begins by reviewing the maternal history to identify risk factors such as smoking, drug abuse, chronic maternal illness, hypertension, multiple gestation, meaning more than one baby in the womb, or any type of genetic disorders. So at less than 28 weeks for SGA babies, this is leading to overall growth restriction, so they never really truly catch up in size at this age. Greater than 28 weeks is intrauterine malnutrition, so they have a normal growth potential with optimal postnatal nutrition. Just a little review, IUGR, if you've never heard of this term before. This is intrauterine growth restriction, and this is when a fetus does not grow as expected, and the baby would not be as big as would be expected for the stage of the mother's pregnancy. This is commonly caused by inadequate maternal fetal circulation. Please carefully review this slide. You need to understand typical characteristics of the SGA newborn. The following are common problems of the SGA newborn. You'll notice that these are pretty repetitive through this lecture with other newborn birth size variations. So perinatal asphyxia, difficulty with thermoregulation, hypoglycemia, so low blood sugars, polycythemia. If you're not familiar with that, it's an increase in red blood cells and it's reflected on hemoglobin and hematocrit levels, and we know these levels through complete blood count lab draws. Meconium aspiration, so sometimes newborns have their first stool while in utero, and this is a huge risk for aspiration upon delivery. Hyperbilirubinemia, I could go pretty in depth with this, but if you're not familiar with this condition, it's when there's a buildup of bilirubin in the blood. The pigment is yellow, so that's what causes that jaundice appearance through assessments. Newborns cannot easily get rid of bilirubin. They can, get rid of it through stooling, so that's why it's important to monitor stools and how frequently they are stooling. On units, we use bilitool.org typically, and this helps, create policies that tell you when to do those bilirubin checks and when to intervene. So, if the bilirubin levels are too high, we typically like to start doing phototherapy as soon as we can. And then, of course, birth trauma is a risk. Nursing management of the SGA newborn, so interventions may include obtaining weight, length, and head circumference, and we compare them to the standards and we document the findings. We do serial blood glucose monitoring, so every unit has a policy set towards this. We want to monitor vital signs. Typically, this is every 4 hours on these newborns or per provider preference and order. Early and frequent oral feedings are typical, and sometimes we have to start IVs on these little babies and start an infusion of dextrose 10% to help their blood sugars stay at a good level. We want to monitor for signs and symptoms of polycythemia, and we also want to provide anticipatory guidance. Checkpoint. Is the following statement true or false? The majority of small for gestational age newborns experience intrauterine growth restriction. The answer to this is false. Some SGA newborns experience IUGR. However, not all SGA newborns have IUGR. The following are risk factors associated with large for gestational age newborns. So maternal diabetes mellitus or glucose intolerance, multiparity, prior history of a macrosomic infant, so a large baby, post-dated gestation, maternal obesity, a male fetus, as well as genetics. Please familiarize yourself with common characteristics of the LGA newborn. These differ from the assessment of an SGA newborn. The following are common problems of the LGA newborn. So birth trauma, in this case, a large baby, this increases a very high risk for a shoulder dystocia. Hypoglycemia, polycythemia, like I said, these are repetitive. And then hyperbilirubinemia. One thing I do want to add about that is if this is not treated in babies, this can lead to kernicterus, and it's a rare but serious complication of untreated jaundice in babies, and this can damage the brain or the central nervous system. So that's why we take bilirubin levels very seriously in newborns. This is a great image of a newborn receiving phototherapy, not always in an isolette. Sometimes it's in a crib with lights above and lights below the crib. It all depends on the provider order because there's single, double, triple lights. Important to note, only goggles on, no swaddle, and just a diaper. You want to make sure the newborn doesn't overheat. One thing I like to always educate the parents on is when the newborn stools and voids, when they go to change the diaper, sometimes it looks bright red because of the light reflections. It's important to educate them on that prior so that you don't want to scare them. And it's, it would scare me too if I didn't know. Nursing management of the LGA newborn, so vital signs per policy, blood glucose level monitoring, initiation of oral feedings with IV glucose supplementation as needed per order, continued monitoring for signs and symptoms of polycythemia and hypoglycemia, hydration, as well as phototherapy for those increased bilirubin levels. Gestational age variables. So term is born from the first day of the 38th week through 42 weeks gestational age. Preterm are born before completion of 37 weeks. However, late preterm is born between 34 and 36 6/7 weeks. That fraction is just saying there's 7 days in a week, so it's day 6 out of the 7 days in a week. Postterm, born beyond 42 completed weeks. This is very risky because the placenta does not perfuse as well. It starts to get old. Postterm newborns, so like I just mentioned, inability of placenta to provide adequate oxygen and nutrients to fetus after 42 weeks, so that placenta is not perfusing as well. Nursing assessment, typical characteristics of a newborn. They usually have dry, cracked, wrinkled skin, and it's possibly meconium stained. So once they get closer to term, they do stool within the womb most of the time. So that's why they have the meconium staining. Long, thin extremities, long nails, creases over entire soles of feet. They're wide-eyed and they have an alert expression. They have abundant hair on their scalp. They have a thin umbilical cord, and they have limited vernix and lanugo. The following are common problems of the postterm newborn. Nursing management of the postterm newborn, like I said, very repetitive. Blood glucose level monitoring per policy, initiation of feedings, getting IV dextrose 10% if having a hard time keeping up with those blood sugar levels, prevention of heat loss, evaluation for that polycythemia, and parental support. Etiology leading to preterm birth include the following. The strongest risk factor for preterm birth is a previous preterm birth. It is usually difficult to identify the cause of preterm labor, but the 4 general causes do include uterine bleeding, so conditions like placenta previa, which is when the placenta is partially or completely covering the cervix, and placental abruption, which is when the placenta separates from the uterus before delivery, which of course is an obstetric emergency, and this causes vaginal bleeding and can trigger preterm labor. Excessive stretching of the uterus, so having twins, triplets, or more, or having polyhydramnios, so an excessive amount of amniotic fluid around the baby. This can cause greater than usual stretching of the uterus, which can lead to uterine contractions and preterm labor. Bacteria or inflammation, so bacteria or inflammation caused by an infection can stimulate the production of substances in the uterus, placenta, and or baby that trigger uterine contractions. An example of this is when a woman gets a UTI. They usually start to contract a little bit and they get admitted into the hospital. And, we treat that. Physical or psychological stress. So severe stress may lead to the release of hormones that cause uterine contractions and preterm labor. Since a preterm newborn does not remain in utero long enough, every body system may be immature, and this affects the newborn's transition from intrauterine to extrauterine life and places him or her at risk for such complications. You need to familiarize yourself with common characteristics of the preterm newborn. Checkpoint. When assessing a preterm newborn, which would the nurse expect to find? Limited lanugo, few palmar creases, wrinkled thick skin, or a wide-eyed expression. The answer here is few palmar creases. A preterm newborn characteristically has few or no creases on the soles of the feet and palms. Lanugo is abundant, and the skin, although wrinkled, is thin. Typically, the eyelids are fused. The following are common problems of the preterm newborn. However, you need to know that the biggest problem preterm newborns face is underdeveloped lungs. Also, preterm newborns get cold very easily. The biggest metabolic consequence is oxygen utilization. Increasing their respirations is their way of compensating for their temperature. The reason why newborns get cold easily, especially preterm newborns, is due to the immature temperature regulating center in their brain, their minimal body fat to retain body heat, their immature glucose control mechanisms, and their decreased availability of alternative fuels in preterm newborns. Page 850 in your Chapter 23 Ritchie book mentions more about the central nervous system and why preterm newborns have a tough time regulating their body temperature. The ones I just mentioned are definitely worth remembering. So why is an isolate so important? This permits the newborn to maintain a normal core temperature with minimal oxygen consumption. Also, it simulates the enclosed uterine environment, especially for any stressful procedures. The following is nursing management for the preterm newborn. It's very important to encourage the parents to support the newborn during this time. Explain the equipment first to them and then focus on the newborn. Regarding thermoregulation, here is a great example on nursing management. So if you have a stable preterm newborn who is breastfeeding very well, what a miracle, right? Who suddenly has a rectal temperature of 97 degrees Fahrenheit, is irritable and slightly jittery. You should place the newborn on a radiant warmer first. You want to assess the situation. Slightly jittery is okay. Very, very jittery, if you're curious what that is entailing, probably a low blood sugar. However, in this situation, you want to place the baby on a radiant warmer first to make sure that the baby gets warmed up. Nurses play a key role in assessing a newborn's pain level. They should be assessed frequently, especially because pain is considered the 5th vital sign, right? Pain can be differentiated from agitation by observing vital signs, behavior, facial expression, as well as body movements. Depending on the unit you're on, pain scales are used for the newborns because they can't communicate, right? They're very vulnerable. Some examples are the Neonatal Infant Pain Scale, also known as the NIPS, that evaluates respiratory patterns. Another one is the Premature Infant Pain Profile, the PIP, which assesses heart rate and oxygen saturation. And then lastly, the CRIES tool. This measures, or not measures, but assesses for crying, requirement of oxygenation, increased vital signs expression, as well as sleeplessness. Please familiarize yourself with the last slide, as well as this current slide on pain management. Just to give you a great example of how to avoid pain when removing an IV from a preterm newborn, for instance, the nurse should slowly pull it out horizontally after wetting the adhesive with saline gauze. This is great practice for all newborns. Checkpoint. When feeding a newborn born at 35 and 2/7 weeks gestation, what should the nurse anticipate? Well, being a preterm newborn, a weak suck and falls asleep. It's so important to discuss this with the parents prior to the newborn being born, if you can, of course. And you should really talk about supplementation and different ways they can supplement their newborn. I could go a little bit more in depth, but I'm just going to leave it there. But just know that it's important to note that these newborns do have a weak suck. They don't have those reflexes fully established at this point, and they could fall asleep a lot, and this can cause feeding difficulties. Perinatal loss is going to be discussed further in a future lecture. However, I just want to stress the importance. It's so important to sit quietly and observe. This is huge and maybe all the family needs. It's okay to not understand what to say or know what to say. It's important to remain open and non-judgmental, and you should explore what might be helpful and use useful strategies to bridge cultural differences. Perinatal loss is any pregnancy loss and/or neonatal death up to 1 month of age. It's a profound experience for the family. Avoidance is a common reaction, and nurses must be aware of their own personal feelings. And like I said, not something you need to know right now, but this was mentioned in your chapter. But this will be discussed in future lectures. But keep this in mind as you start your rotations.